in medical imaging, the bachelor's portion of our program at Clarkson, I'm going to talk a little bit about each one of these. So CAT scan or CT, MRI, angiography, mammography, bone densitometry, and imaging informatics. So CT. Fine. CAT scan. You guys all said you kind of heard it. The posters were in the other room. I do see PET scan, and sometimes they use CT in conjunction with PET scan to get a better diagnosis. And what CT does, you see this gantry back here, this donut right there. There's an X-ray machine in there, and there's like a detector or a film on the bottom, and it rotates around the patient, emitting X-ray. And as it rotates, it takes pictures, and then all those pictures go into a computer. Computer puts them in a nice little data set, either of your head, of your chest, abdomen, pelvis. And what we can do is slice them like a loaf of bread, take those slices out and look at them. So on this, you can see this is a slice of the brain. So it's basically, it's a pie, so this slice is, and so I've sliced the patient's brain, taken it out and looking at it. So we can see things better. We can see that there's a little area, like a stroke there. And that slice is an axial slice, so it cuts the body into superior and inferior sections. What the cool thing is, and what drew me to CAT scan, is the 3D aspect. It was like playing video games. I mean, I like Pac-Man, that's my thing, or Frogger. Those are like 80s, 90s games. But it really, that's one of the things is because there's a separate workstation, and I can take that whole data set and send it over to the workstation, and I can make this 3D. I can, make it look like it's real, like give it shades that it would have in the body, and so it would look real. And I work closely with the surgeons for surgical planning. Like if they are going in to look at this, I could take that section of the brain out and just have it there and make it tumble, make it roll, and so that the surgeon can see exactly the parameters of that mass or that stroke. And one of the other things is, so that data set, if I gave the patient contrast but highlights their blood vessels, I can take the blood vessels out of that data set and mess with it on a 3D workstation. So it's pretty cool, and we can go actually inside the blood vessel, and I can use the mouse and go up and see if there's any like stenosis where the blood vessel would be narrowing, or there's blood clots in there. So that was pretty cool. One of the reasons why I went into CT, and the other reason I went into CT and MR is I like starting IVs. I know that's kind of sounds awful, but in X-ray I didn't start a lot of IVs. In CT and MR, I started about 25 per day. This is MRI. This is the bore of the MRI where the patient goes in. And MRI is kind of cool. Yes?
Isn't it frustrating when you can't get the IV in?
Yes.
Yeah, because it's frustrating when you're the person who...
It absolutely is. So that's what, I usually have a rule. I try twice. If I can't get in the second time, I go get someone. Because I don't like that when when people do that to me as a patient.
Yeah, I got tried 9 times.
Oh,
and the anesthesiologist couldn't even do it.
Oh, for heaven's sake. Yeah. And a lot of times we go get an ultrasound machine and try to find it then. But that's what I teach in my patient care class. I teach them, you should take care of someone as if they're your mom, dad, sister, and brother. So you treat them as you would your family. If you do that, then you're good. So MRI, this baffles me, and one of the reasons I went into MRI was, if you think about it, who thought about if I put someone in a magnet and bombard them with radio frequency, that we would get an image. It just baffles me that someone thought of that, like, the big magnet here, if I did put someone in there. And so what happens is we put the patient inside the board, and then we bombard them with radio frequency. Like the TV towers, it sends radio frequencies out to your TVs. The radio towers sends radio frequencies out to your radio, so we can watch TV and listen to the radio. Same type of radio frequency we use in MRI. So what is your body mostly made up of? Water. What is water made up of?
Hydrogen.
2 hydrogen?
Oxygen.
Or 1 hydrogen, 2 oxygen, right? Or, no, 2 hydrogen, 1 oxygen. so those little hydrogen protons act like tiny bar magnets. And so when we put them in a huge magnet, they follow the rules of magnetism. So when we bombard them with the RF, the protons flip to align with the RF. Actually, inside your body, in the MRI, the protons are moving. We can control them with the RF. But you don't feel it. The patient doesn't feel it. When we take away that RF, they have to go back aligning with the magnet, and they emit energy. And that energy, or that signal we get, is how we make our image. So we're imaging at the molecular level, which is unbelievable to me. And so the images in MRI are very, very detailed because of that reason. And so we use MRI to look at your ACL on your knee, your rotator cuff in your shoulder, things that are soft tissue. We do image in MR. Angiography is pretty cool. It is, you're always in a sterile suite, or a surgery suite. So you're wearing surgery scrubs, hat, mask, gloves. And what we do is we inject contrast in a vessel and then image it. And we're looking for strokes or blockages in the heart. So right here, this is an angio of the vessels in the brain. And we also do it we work with cardiologists and vascular surgeons and neurosurgeons. So it's a big team that works in angio. Mammography, that is imaging of the breast. The American College of Radiology says that, recommends that women over 40 have mammograms. So always job opportunities there. Bone densitometry, it is a scanner that looks or measures how dense your bones are, okay, whether you have osteoporosis or not. And that kind of goes with mammography as more of an imaging, women's imaging center. And then imaging for informatics. So if you don't like blood, yucky stuff, patient stuff, you don't want to work with patients, but there is a behind-the-scenes degree in radiology, and that's imaging informatics. All of our images now are digital. We don't have films anymore, so they all go to a central database, and someone has to manage that. So that's what this imaging informatics is. Let's skip here. So one of the things I forgot to tell you, and I'll tell you real quick, that kind of makes us different than everyone else too, which I loved as a student, is we have an energized lab in our college. So in the basement on 42nd and Dodge, we have an energized lab, and what that means is we can take x-rays there. And we have a phantom, we named her Glenda, so we x-ray Glenda. So that first year that they don't go out to clinical, a lot of people say, well, they don't even get an x-ray till they go out to clinical their second year. That is not true. We have them x-ray and do exams on Glenda, so then if they make a mistake, guess what? We're there. We're there to say, hey, no, we don't do it that way. This is the way you do it. They remember it. They comp on it in front of us. So that way, hopefully, they won't make mistakes on our real patients. So it's one of the perks, I think, of Carson College. So what do we do on a daily basis? We x-ray broken bones. That's one of the things. So here's this patient. He's a 25-year-old male who has a complete fracture of his left distal tibia and fibula. Where's your distal tibia and fibula? Lower leg, right? And so that's usually what I get across my computer, saying that this is what happened. And then I go over to the ER, and this is what I see. So it's usually, brought in by ambulance, and we see they usually have some sort of splint, whether it's an air splint or a cardboard splint like that. So I have to talk to my patient. That's one of the key things of being a good healthcare provider, is if you can communicate well with people. And so I have to tell them, hi, my name is Trish. I'm going to be your x-ray technologist today. And we're going to get a couple images of your leg. I'm going to try not to move it as much as I can, because is it going to hurt if I move that?
Yes.
Yes. Yes. And so very carefully and slowly, I put a plate underneath their leg. Okay? Because I have to shoot an anterior to posterior view. So it the x-rays have to go anterior, exit posterior, and hit the x-ray film or cassette. Okay? I also have to get a image 90 degrees to the AP. So I have to shoot a lateral. So I have to put my x-ray machine here, and put my x-ray cassette on the other side and shoot a lateral to look for displacement of the bone. Okay? And this is what I get. So this is my AP projection, and I see that he has a fracture of his distal tibia, which was kind of evident with the backward C in the image before. Is that